This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, it's Jeff Ratliff with Thomas Jefferson University and the Neurology Podcast. I'm here with Gregg Day from the Mayo Clinic in Jacksonville, Florida. Listeners will recognize Gregg from his work as both interviewer and interviewed author on the podcast over the years. Today, I'm going to be talking with Gregg about his paper published in the Annals of Neurology in October of this year, titled Improving Early Recognition of Treatment-Responsive Causes of Rapidly Progressive Dementia, the STAMP-3 score. On November 28th in 2022, Justin Abutamarco interviewed Gregg to discuss his paper that was in Neurology Clinical Practice on improving early recognition of Creutzfeldt-Jakob disease and distinguishing it from its mimics. In this paper, Gregg and his colleagues present their development of a clinical calculation tool to help us better identify patients with treatable causes of rapidly progressive dementia from a prospective cohort. Gregg, welcome back.
Thanks, Jeff. Appreciate it.
So, Gregg, getting right to it, can you tell me what did this study teach us about how to better identify patients with a treatable cause of a rapidly progressive dementia?
First things first, Jeff, we got to realize that these patients are out there and we got to be actively looking for these patients. What I like best about this collaborative work, and it really is collaborative, led by a fantastic medical student, now an even better neurology resident here at Mayo Clinic in Florida, that's Nihal Satyadeva. But this manuscript combats the idea, a pervasive idea, that CJD is actually the most common cause of rapid progressive dementia. In effect, what we're showing here in this paper is that potentially treatable causes comprise a majority of patients who we prospectively encountered over a prolonged recruitment period. 86 of 155 patients that we enrolled, that's 56%, had a potentially treatment-responsive cause of their rapid progressive dementia. Second most common causes here, that was neurodegenerative diseases. So I'll say atypical presentations of typical neurodegenerative diseases like Alzheimer's, Lewy body frontotemporal dementia, followed by CJD in third place. So if you're looking for patients, if you're expecting to find patients that might have treatable causes, you're going to be more likely to recognize them when they present to your office, emergency department, or you're seeing them on the consult service. And what this work suggests is that we can find these patients using clinically accessible tools, the things that pretty much all of us have at our daily disposal. That's history, physical examination, and MRI and CSF findings. And if we apply these findings, I think we're going to get better at recognizing these patients early in the clinical course, perhaps when they first present to us, which we hope is going to create opportunities to treat them earlier. What we ended up finding being the most important, the distinguishing features behind the potentially treatment-responsive causes, early seizures, a tumor that could be associated with autoimmune encephalitis or paraneoplastic encephalitis, MRI with findings that looked like autoimmune encephalitis, so that's a point where we might have engaged our radiologist to clarify, early features that include mania, movement abnormalities, and of course, pleocytosis in the CSF, so increased white blood cell count that can indicate an underlying inflammatory or autoimmune process. When we add in age younger than 50, recognizing that autoimmune, inflammatory, treatment-responsive causes are more likely in younger patients, we end up with this STAMP-3 score, whatever you want to call it, that can be applied to help us recognize these patients. And 83 of 86 patients with potentially treatment-responsive causes in this series had at least one of these STAMP-3 features.
Rewinding and discussing how we got here, this was a prospective cohort study of patients with suspected rapidly progressive dementia. And I find myself teaching residents, teaching students that while clinical scoring tools are often really helpful, it's critical that we know who or to which patients should we apply these scores and calculators that are out there. And so in this study, what were the clinical features or qualities of the patients who were studied in this cohort? And accordingly, how would you advise listeners to select patients on whom to go and plug in clinical data and calculate and apply this score that you developed?
For this study, ultimately, we started by restricting things to adults. I'm an adult neurologist, a behavioral neurologist. I typically only see adults, and that's whom I'm most comfortable with. And so that's a part of the restrictions on this cohort. The next criteria here is that to enter into the clinical calculator that derives the STAMP-3 score, patients had to have rapid progressive dementia. And so while we started with patients who we thought could have rapid progressive dementia, the 155 patients that we're actually pulling data from, those are individuals with confirmed rapid progressive dementia. Now, points to keep in mind on that. The number one cause of rapid progressive dementia is an incomplete history. And so we start all of these consults for suspected rapid progressive dementia by engaging with a reliable collateral source, a family member that knows that patient well and who can really tell us when was the beginning of symptom onset, the first time that there began to be some cognitive changes that are ultimately going to culminate in dementia. And that leads us to see our initial cohort, shrink from 226 patients with suspected rapid progressive dementia down to 155. We define rapid progressive dementia as dementia that moves from the very first symptom onset to dementia within 1 year, or from the first symptom onset to complete incapacitation. That means being entirely dependent on someone else for your activities of daily living within 2 years. And so we really are talking about an aggressive, progressive form of dementia when we talk about rapid progressive dementia. Second, for this cohort, we were really interested in focusing on patients with rapid progressive dementia due to unclear causes. And so what do I mean by that? Well, we eliminated patients who had dementia or encephalopathy that developed right after a large hemorrhagic or ischemic stroke. The MRI, the CT scan tells you right away what that patient has. And so they're not in the cohort either. We also eliminated patients with dementia developing right after a big TBI, again, a fixed cause, or those who presented with clear and fulminant meningitis or encephalitis, arguing again that we're going to use other scores, we're going to use clinical acumen to recognize those patients right out of the gate. So what does this mean in clinical practice, and if you want to apply these results? Well, if a patient comes in under a code stroke, if they come in with obvious fevers, neck stiffness, do not be standing around pondering how to apply this score, how to count up the different points on the checklist. Get straight to treatment and move on. But if you're called to see a patient, maybe in the emergency department, maybe on the consult team, maybe they get admitted to your service or they walk or wheel into your office, and you're getting this history of really rapid progressive declines leading to dementia in a short period of time, you're confident in that history, and you don't have an obvious explanation, that's exactly the patient type that we want to be thinking about the STAMP-3 score for, to try to identify potentially treatment-responsive causes.
To summarize that, it's patients in whom a careful history of both the patient and a reliable caregiver or someone close to the patient who's had really that progression from onset within a year to impairment or within 2 years to total dependency, with the caveats and these sort of big secondary causes, stroke, other brain lesions, brain injury, meningitis as also not being included. So I think our listeners hopefully have a good sense of on whom to apply this score going forward. Once you followed patients and determined whether they had a treatable or non-treatable cause of their rapidly progressive dementia, and you mentioned some of the common etiologies, one being a primary neurodegenerative disease like Alzheimer's disease that may have progressed maybe atypically rapidly. But can you help sample some of those two columns? What were some of the more common treatable causes of rapidly progressive dementia, and what were some of those more common non-treatable causes as these cohorts started to distinguish themselves?
Far and away, the number one most common cause of potentially treatment-responsive rapid progressive dementia were autoimmune diseases, in particular, those that we're going to associate with autoimmune encephalitis. And so on the whole, that included 52 of the 86 patients that make it into the potentially treatment-responsive category. So that's 60%. They're followed by vascular disease. And while we excluded large strokes, it is, of course, possible that patients could have subsequent small strokes that are evolving slowly over time, not presenting as a code stroke or anything of that sort, that culminatively impair cognition and can contribute to or cause rapid progressive dementia. And so that can be vascular disease from stepwise ischemic infarcts or hemorrhagic infarcts, and a few cases of inflammatory vasculitis. And so getting back to the autoimmune/inflammatory category, that adds up there as well. There were a few hematogenic malignancies, toxic metabolic vitamin deficiencies as another category of importance. Psychiatric presentations do exist, but ultimately those ones all accounted for less than 10%, so paling in comparison to the autoimmune inflammatory cohort. On the non-treatable side, those atypical presentations of common neurodegenerative diseases, Alzheimer's disease, Lewy body disease, FTLD, while there are certainly medications that can help those patients, we don't truly consider those diseases treatment responsive, as we're not yet able to stop or prevent further progression in those disease categories. And so they make up the bulk of the non-treatment responsive causes, and we can add prion disease into that category as well, certainly one we recognize as a relentlessly progressive and fatal cause of rapid progressive dementia.
Now it's time to really get down to what is the score, what goes into it. There's the name of the score. It is an acronym. It's STAM with a 3 and then P, which you have turned into that acronym. So we can call it STAM3P. We can call it STAMP3. I don't know if you have a preference on what this is going to be called going forward for clinicians who are putting it into practice.
Well, here's the reality, Jeff, and you're calling me out on it, but we really wrestled with this one. We want, like every good neurologist, to come up with a catchy and memorable acronym that's going to be easy to kind of jog in the mind, remember, rehearse, and apply in clinical practice. But what we learned is that a true data-driven approach, which is what led to these individual features, doesn't always yield the right letters of the alphabet that we want to mix into things. And so the reality here, I organized things as best as I could in many different combinations, really every iteration, and STAMMP or STAM3P is about the best that we can do to create something that we can keep in our mind. So in truth, I don't care if we call it the STAMP score. I don't care if we call it the STAMP3 score, maybe a little bit easier to say. I don't even care if you call it the STAMP score. I mean, whatever it needs to do to get the message across. What we really hope is that this score and the data that underlies it, the principles that are embedded in it, are applied in clinical practice, and hopefully will be found to be of high yield findings in your practice and other practice in helping to recognize these patients early. I just recommend that people really use the score or compute the score like we did. Complete a thorough assessment of your patient with suspected rapid progressive dementia. Confirm that they have rapid progressive dementia and that there's not some other obvious cause for which you don't need this score. And once you're done, once you finish that initial assessment and you've ordered your standard tests that are very important in evaluating patients with rapid progressive dementia, that's neuroimaging, typically CSF analysis, some serum studies, and EEG, sit down, add up the score, and really consider it as a checklist. The checklist is balanced between history and physical exam findings, so things that we're going to find on that first encounter at presentation, and we're going to look for seizures, younger age, that's age under 50, mania, and early prevalent movement disorders. All of those are going to be checkpoints that we want to be screening for. And we're going to add in some results, early results, the things that come back to us very quickly from widely accessible tests. And that includes the suspicion or finding of a tumor that may be associated with brain disease, paraneoplastic encephalitis, brain MRI findings of encephalitis, that could be T2 flare hyperintensities with or without contrast enhancement in the temporal lobes or in other parts of the brain. And finally, elevated white blood cell count in the CSF pleocytosis.
And so S for seizures, looking for signs of early seizures. T for tumor, either brain tumor or maybe a non-CNS tumor that's triggering a paraneoplastic or tumor-associated response. A for age under 50. And then our 3 M's with MRI findings consistent with encephalitis or other abnormalities. M for mania as a neuropsychiatric feature of the syndrome, M for movement disorders, and then P for our CSF testing showing pleocytosis. Did I get through that properly?
You nailed them all. That's perfect.
And so based on that sum or what the score computes for them, how do you advise clinicians proceed based on cutoffs or features of that score total that they come up with?
And here's another insight into the back room on analyses. Nihal and I considered this in many different ways, looking to comprise some complex nomogram where 1 point for this, 2 points for that, and a score above 4 could signal something. But the reality was that each of these points warrants attention and warrants potential reaction or at least stronger consideration of a potentially treatment responsive cause of rapid progressive dementia. And so there is no need to add them up with any complicated formula. The reality is that if you've got one check mark on the STAMP3 score, you're going to want to pause and recognize that that patient is at a higher risk of having a potentially treatment responsive cause. And this is a trigger to maybe expand the workup that you've started or in the process of completing. And so maybe add on those tests for autoantibodies in blood and spinal fluid if you think an autoimmune cause could be a realistic contribution. Might be some of the advice there. Maybe do some additional screening and think more broadly about other causes. If it's inflammatory vasculitis or vasculitis of any kind, perhaps some vascular imaging, all things that warrant consideration. But if you're looking at your checklist and you're seeing 2, or definitely if you're seeing 3 check marks there, this is a patient where we really want to expand that workup. Make sure that we're looking for that definitive cause, but probably while we're expanding the workup, also consider early intervention with what we can call first-line therapies or first-line treatments. If that patient has a score of 3 or higher, well, I'm going to suggest that treatment really becomes a very high priority for those patients. Ultimately, a STAMP 3 score of 3 or higher had 100% positive predictive value for treatment responsive causes. And so warrants very strong consideration there. Of course, balancing that against the potential risks of treatment. You want to be confident you've ruled out an infectious cause that might present an increased risks to the patient receiving steroids. We probably also want to be pretty confident that we've excluded diseases that a steroid course might impair our ability to get to the diagnosis down the road. And I think the two most common ones we think about there, lymphoma of the central nervous system and also potentially sarcoidosis. And so let's use this score to intervene early in our patients, because we do know that for patients with potentially treatment responsive diseases, time to treatment is inversely correlated with potential outcomes. So shorter time to treatment, better potential outcomes. And that's really what this is all about.
I think that's fantastic. I've been speaking with Gregg Day from Mayo Clinic in Florida about his paper in Annals of Neurology titled Improving Early Recognition of Treatment Responsive Causes of Rapidly Progressive Dementia, the STAMP 3 score. Gregg, thanks again for joining us.
Thank you, Jeff, for the opportunity.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.